So which of the following is found between the bone and implant of an endosseous dental implant? Periodontal ligament, peri-implant ligament, epithelial ligament, or bone implant interface. Bone implant interface. The histologic definition let's see, let's adjust something here. The histologic definition of osseointegration is best described by the following: the direct connection between living bone and a load-bearing endosseous implant at the light microscopic level. Only endosseous and transosseous implants are considered true osseointegrated implants. Criteria for success of dental implant: clinical immobility under load-bearing conditions, symptom-free, minimal loss of crestal bone, no peri-implant radiolucency. Notes: 1. For an implant to be successful, you need adequate transfer of force and biocompatibility. 2. Handpieces for preparation of dental implant receptor sites are low speed, high torque. Note 3. In the event an endosseous dental implant is mobile, the proper procedure is to remove the failed implant, debride the socket, and consider placing a bone graft with a resorbable membrane. You need a minimum of 10 millimeters. Another note: you need a minimum of 10 millimeters of bone height to place an endosseous root form dental implant. The minimum required distance from the apex of a mandibular posterior implant. Minimum required distance from the apex of a mandibular posterior implant to the superior aspect of the inferior alveolar canal is 2 millimeters. 6. Note 6. Titanium and titanium alloy are the most common materials used today for two-stage endosseous implants. Which of the following factors would have the greatest negative influence on dental implant success? Hypertension, patient over 70 years of age, smoking, alcohol, post-bypass surgical patient. Smoking. Because smoking affects the healing of bone and or overlying tissue, it should be considered a relative contradiction to implant placement. Any toothless area can be considered for dental implants. Determining whether implants are an option and the type of implants to use include the patient's requirements and expectations, the amount of additional work needed, i.e. bone grafting, the dentist's skill level, and the long-term prognosis. Some indications for implant placement: number 1, fixed restoration of single or multiple teeth in a partially edentulous area. Number 2, retention of a removable prosthesis in a partially edentulous jaw. Three, retention of a prosthesis in a completely edentulous jaw. And last, retention of a fixed prosthesis in a completely edentulous maxilla or mandible. Important. Important. In patients with uncontrolled systemic diseases, such as diabetes, immunocompromised patients, and patients with bleeding disorders, implant placement should be considered with extreme caution. Remember, the highest failure rate is seen in the posterior maxilla, where the bone is softer. It is the softest quality, which is D4. Mobility of the implant is regarded as the most common sign of implant failure. Third point to remember: a dental implant supported prosthesis should fit passively on the dental implant. Next point to remember: the minimum space required for a 4 millimeter diameter implant is 7 millimeters. 1.5 millimeters on each side of the implant plus the diameter of the implant. The maximum amount of taper to allow for proper draw of an overdenture attachment, such as an O-ring, is 15 degrees. Currently, the most popular used implants are blade form implants, no. Subperiosteal implants, no. Transosseous implants, no. Root form implants. Dental implants are divided. Keep knocking this. Dental implants are divided Dental implants are divided into three categories based on their relationship to the oral tissues. One, endosseous implants are implants that are surgically inserted into the jawbone. They are the most frequently used implants today. They are further subdivided into root form and blade form. Two, the second category of the dental implants are subperiosteal implants, which are frameworks specifically fabricated to fit on top of supporting areas in the mandible or maxilla under the mucoperiosteum. This type of implant rides on bone. Third category of implants: transosseous implants are implants that are similar to endosseous implants in that they are inserted into the jawbone. However, these implants usually penetrate the entire jaw so that they actually emerge opposite the interside, usually at the bottom of the chin. Note, their primary indication is in the very atrophic mandible, where root form implants may further compromise the strength of the jaw. Remember, osseointegrated implants are anchored directly to living bone. This determination is made by radiographic and light microscope analysis. Only endosseous and transosseous implants are considered to be osseointegrated implants. Root form implants and blade implants. The root form implants are cylindrical in shape, can be smooth, threaded, perforated, and solid or hollow, vented, coated, or textured. They are available in various widths, 3.2 millimeter to 7 millimeter. Also lengths 8 millimeters to 18 millimeters. Typically made of titanium. Treatment with root form implants is divided into 3 stages: surgical, healing, and prosthetic. Note, these implants are the most popular. And then there is a blade implant. Blade implants, also known as plate form implants, are flatter in appearance and are utilized where there is insufficient width of bone but adequate depth. They are available in a single and 2-stage forms, typically made of titanium. Two basic types of implant placement: submerged requires a second surgical procedure to uncover the fixture, and the non-submerged does not require a second surgical procedure because it's all one stage. I think I have read all these cards. To prevent infective endocarditis in patients at risk for such infections, the American Heart Association frequently issues guidelines for prophylactic antibiotic coverage during dental procedures. In accordance with the most recent revised AHA guidelines, which of the following are acceptable antibiotic options for the prevention of infective endocarditis? Well, amoxicillin, clindamycin, and erythromycin, I believe. I guess all of them, except one. I don't care about that one, I care about these that are good. So cephalexin, amoxicillin, clarithromycin, azithromycin, clindamycin. In adults, the new antibiotic regime recommended for the prevention of infective endocarditis is amoxicillin 2.0 grams, (30 to 60 minutes prior to the procedure, which is about 4 tablets of 500 milligrams. For those patients allergic to penicillin, clindamycin 600, 30 to 60 minutes before the procedure, about 450 milligram tablets. Guidelines for children are amoxicillin 50 milligrams per kilogram, 30 to 60 minutes prior to procedure. For those patients allergic to penicillin, clindamycin 20 milligrams per kilogram in children, 30 to 60 minutes prior to the procedure. These new guidelines involve a number of changes from the previous set of guidelines. Only one antibiotic dosage is required. The recommended antibiotics for penicillin allergic patients is clindamycin, not erythromycin. Prophylaxis is no longer required for many dental procedures. Alternatives for patients who are allergic to penicillin and who cannot take clindamycin include cephalexin, clarithromycin, and azithromycin. The roots of the third, second, and first molars are all below the level of the malohyoid. Infection of these teeth pass through the root directly into the submaxillary space and then to the lateral pharyngeal space. Remember, the malohyoid muscle stretching across the floor of the mouth serves as an inferior border of the subgingival space and the superior border of the submaxillary space. Facial spaces and infections. The spaces on the left, the usual sources of infection are on the right. In maxillary spaces, canine buccal spaces or infratemporal spaces, canine spaces are usually the usual source of infection is the canines. In a buccal space, the source of infection, the most usual source of infection in a buccal space will be maxillary molars, premolars, and the infratemporal space will be the maxillary third molar. And those are the usual sources of infection. Now, in the mandibular spaces, we have the buccal space that its usual source of infection will be the mandibular molars and the premolars. The submental space, the sources is the mandibular incisors. Sublingual space, mandibular molars or premolars. Submaxillary space, mandibular molars. Pterygomandibular space, mandibular molars and premolars. Anyway, anatomic variability exists, and the descriptions given above represent the space in which an infection from a tooth is most likely to drain. Note, penicillin V is often the preferred drug to treat odontogenic infections. It is effective against streptococci and oral anaerobes. For penicillin allergy patients, clindamycin or clarithromycin can be used. Narrow spectrum antibiotics are preferred over broad spectrum antibiotics, and bactericidal agents are preferred over bacteriostatic agents. The mandibular left second molar of a 14-year-old boy is unerupted. The mandibular left second molar of a 14-year-old boy is unerupted. Radiographs show a small lentigious cyst surrounding the crown. What is the treatment of choice? Treatment of choice is surgically extract the unerupted second molar, undercover the crown and keep it exposed. Prescribe anti-inflammatory medications. And schedule a follow-up appointment in 6 months, or no treatment is necessary at this time. Uncover the crown and keep it exposed. The intergerous cysts are those associated with crowns of unerupted teeth. Some literature refers to them as follicular or primordial cysts. Note, they are probably the result of degenerative changes in the reduced enamel epithelium. Remember, if cysts form when a tooth is erupting, they are called eruption cysts. These cysts interfere with normal eruption of teeth. Eruption cysts are more commonly found in children, in young adult, and may be associated with any tooth. If treatment is indicated, simple incision or the roofing is all that is needed. And last one, because I'm very sleepy. I need to go exercise now. I'm gonna go to sleep. Which of the following are considered primary facial spaces? Select all that apply. Primary facial space: buccal, canine, submaxillary, masticator, vestibular. We'll see. Buccal, canine, submaxillary, and vestibular. All of them except masticator. Let's see. Facial spaces or layers of fascia create potential facial spaces. They are called potential because in health there is no space. All are filled by loose areolar or connective tissue. The hyoid bone is the most important atomic structure in the neck that limits the spread of infection. The infections or other inflammatory conditions spread by the path of least resistance to reach the facial spaces. The most common space involved is the vestibular space. The spaces directly adjacent to the origin of the odontogenic infection are primary facial spaces. Infections spread from the origin into these spaces, which are buccal, canine, sublingual, submaxillary, submental, and vestibular. Canine space infections and deep temporal space infections can result in cavernous sinus thrombosis via ophthalmic veins. Facial spaces that become involved following the spread of infection to the primary spaces are the secondary facial spaces. The secondary spaces are pterygomandibular, infratemporal, mesenteric, lateral pharyngeal, superficial and deep temporal, retropharyngeal, masticator, and prevertebral. Note, lateral pharyngeal infections can traverse the retropharyngeal and prevertebral spaces and spread into the mediastinum. Factors that influence the spread of odontogenic infections: number 1, thickness of bone adjacent to the offending tooth. 2, position of the muscle attachment in relationship to root tip. 3, the virulence of the organism. And 4, the status of the patient's immune system. Notes: number 1, the masticatory space contains the contents of pterygomandibular space and is continuous with the temporal space. Note 2, the most definite clinical sign indicating extension of an odontogenic infection into the masticatory space is trismus. Trismus is difficulty opening the mouth due to tonic spasm of the muscles of mastication. Note 3. Trismus may also result from passing the needle through the medial pterygoid muscle during an inferior alveolar nerve block. 4. Other symptoms of facial space infection include pain, dysphagia, and dysphonia. And 5. The submandibular space The submandibular space is continuous with the lateral pharyngeal space. The mylohyoid muscle divides this space and serves as the inferior border of the sublingual space and the superior border of the submaxillary space. Again, the submandibular space is continuous with the lateral pharyngeal space. The mylohyoid muscle divides the space and serves as an inferior border of the sublingual space and the superior border of the submaxillary space. Okay, that's it, that's enough.